Okay, so toxicology and pharmacology. What's the first thing we got to know about in toxicology? Basically, we're going to go through a whole list of drugs here, as you can see, and I'm going to tell you what they do, what to look for, and the antidote for them. So acetaminophen, what are you going to look for? You're going to look for abdominal cramping. It's going to be a big one. Increased liver functions, function enzymes, I should say. So you're going to do LFTs on them, and coagulopathy. Don't overlook that one. Coagulopathy. Alright, so normally acetaminophen is conjugated in the liver to inactive metabolites. However, a fraction of acetaminophen becomes hydroxylated to N-acetyl benzoaminoquinone, and that's also known as NAPQI, in case you're ever asked about it, which is highly, highly toxic metabolite, which can react with what? The sulfhydryl groups of hepatic proteins, forming covalent bonds, which leads to a zone 3 centrilobular hepatic necrosis. Zone 3 centrilobular hepatic necrosis. So, what the main thing here is, what do we need to do to give this? We need to give N-acetylcysteine, right? That's the treatment. Acetylcysteine, which is a precursor of what? A glutathione. So you increase the availability of the glutathione to conjugate this, the NAPQI. Avoid using this agent with patients that have pre-existing what? Liver failure. That would be a biggie. So don't let them try and trick you. If you have a patient on the USMLE that has acetaminophen intoxication and they're in liver failure, do not use N-acetylcysteine. So just be aware of that. All right, moving on to aspirin. Aspirin is going to give you an anion gap, metabolic acidosis, respiratory alkalosis, and then you're going to get tinnitus. So those are the three things you're going to get from aspirin intoxication. Not fun. So the first thing you're going to get is anion gap metabolic acidosis, followed by respiratory alkalosis, then you're going to get tinnitus. No fun. Now the mechanism of respiratory alkalosis is aspirin and other salicylates uncouple the OX-phos pathway, which leads to elevated CO2 and subsequently increases the respiratory rate, right? So high aspirin doses affect the medulla, the medullary respiratory center, which leads to hyperventilation and a respiratory alkalosis that can usually be compensated by decreasing excretion of hydrogen ions and NH4+, as well as resorption of bicarb. So what do you think the antidote is for aspirin intoxication, by the way? That would be bicarb, HCO3 minus. We got too much acid on board. We need to get rid of it with some negatives. And moving on to amphetamines. This is the major pharmacological effect of amphetamines are due to causing its increased release of both dopamine and norepinephrine. Dopamine and norepinephrine. So the vesicles that store these two neurotransmitters, when you take an amphetamine, you're going to cause more dopamine and more norepinephrine. So you're going to get insomnia, dizziness, tremor, irritability, confusion, panic, delirium, yada, yada, yada. Some suicidal tendencies are possible. Chronic amphetamine use can produce symptoms that appear similar to psychotic episodes, such as maybe schizophrenia. So just be aware of that. The cardiovascular effects are the main things you have to worry about. You have to worry about arrhythmias, hypertension, angina, etc. Now, the treatment for this guy, the main acid you use in medicine is ammonium chloride, NH4Cl, because most amphetamines are very basic. So therefore, if you took your amphetamine or your Adderall with food, you would get more bang for your buck, basically. Moving right along to alkaline agents. This is found in batteries, drain cleaner, and detergents. Symptoms are going to be drooling, can't swallow, dysphagia, but also they have a metabolic alkalosis, not acidosis. So what do you think the main antidote here is? You want to treat this with milk right away. Milk, water, make them NPO. They have nothing by mouth to prevent further esophageal erosion right away. So any of these alkali agents, you treat them with anything you can to stop this. So the thing that is concerning in the USMLE likes drooling, dysphagia, and metabolic alkalosis. The only thing that's going to save your butt is the metabolic alkalosis. So if you see a kid that's drooling, a lot of people go straight for what? That whooping cough and all that stuff. Don't do that. Make sure you check to see if their electrolytes are in balance or they're not. And moving right along to the anticholinergics, this is going to be hot as a hair, so you're going to have a fever. You're going to have mydriasis, blind as a bat, dry as a bone, red as a beet, mad as a hatter. You're also going to have delirium. The treatment for this guy, or the antidote, physiostigmine. I wonder why. See that word physio in there? He can cross the blood-brain barrier. All right, moving right along to the organophosphates and the anticholinergics. Symptoms here, if you overdose on either one of these, you're going to have your dumbbells, you're going to have your diarrhea, your urination, your bronchospasm, bradycardia, meiosis, excitation of skeletal muscle and the CNS, lacrimation, sweating, salivation. So if you overdose on the anticholinesterase, what is the antidote? The antidote is atropine, which we have talked about before, or Tupam, or Digoxin. So how about arsenic? Arsenic's a fun little guy. His symptoms, what's your clue for arsenic? You're going to have what are you going to smell on your breath? Garlic. Garlic smelling breath. Garlic. That's your clue. You can have seizures, altered mental status, coma. You can also have these things called Nees lines. That's white horizontal lines on the fingernails. Now, what is the antidote for arsenic poisoning? Dimercaprol. Or gastric lavage. That's the main one, dimercaprol there. So moving right on to benzodiazepines. These target the what? The GABA what receptor? The GABA A receptor, which increases the frequency of what? The chloride channel opening, causing postsynaptic hyperpolarization and inhibiting the action potential generations. Some symptoms are going to be, you're going to be down, excessive amounts of cardiac depression, drowsiness, apnea. So what is the antidote for benzodiazepine overdose? It's flumazenil. Which is a GABA receptor antagonist. And moving right along to beta blockers. So what is a beta blocker simply going to be if you overdose on that? You're going to be hyperkalemic. So you're going to see peak T waves on the EKG. There's one thing you're going to be. You're going to be hypoglycemic, right? Because the beta receptors are on the alpha cells of the pancreas, which release glucagon. You're going to have pulmonary vasoconstriction. So, restrictive lung disease profile, low PO2 or low O2. What else are you going to have? You're going to have bradycardia. So, what do you think the treatment for beta blocker overdose is? Do what the alpha cells can't do in the first place, make glucagon. And moving right along, carbon monoxide poisoning. Carbon monoxide, just treat them with 100% O2, oxygen, hyperbaric chamber, whatever you got to do. How are you going to know if someone has carbon monoxide poisoning, by the way? They're going to get a cherry red skin. That's your clue. And all their mucous membranes are going to be confused, etc. So moving right along to copper, gold, and mercury. These are all big elements here. So with copper poisoning, you're going to have a yellow discoloration of your skin. What disease has too much copper in it? That's right, Wilson's. When there's Wilson's and those Kaiser-Fisher rings. So what about mercury poisoning? You get that from too much consumption of fish, improper disposal of fluorescent light bulb or spills. So how do we treat these guys? How do you think? Oh, I'm going to go with the same one, dimercaprol. Anytime you don't know, you say dimercaprol or penicillamine. Those are two really good ones to go with. All right, cyanide. Now this one's got a funny little thing to it. You'll have an almond-like breath with cyanide poisoning. Almond-like breath. You also have trismus, seizures, etc. What's happening is cyanide poisoning from nitroprusside causes metabolic acidosis with increased mixed venous PO2 because the tissue is not able to utilize the bound oxygen. This is an early sign is tachyphylaxis to nitroprusside infusion. So the antidote is number one antidote. You give amyl nitrate and sodium nitrate. This combination causes oxidation of hemoglobin and intentional formation of what? Methemoglobin. I don't want that to ruin any more of my hemoglobin, so I'm going to form this methemoglobin. Number two, sodium thiosulfate is going to be given, which acts as a sulfur donor to increase the production of thiosulfate, which can be excreted. Thiosulfate. Excrete. And then number three, eventually what am I going to do? I'm going to give you vitamin B12 hydroxycobalamin. I'm going to give you B12. Hydroxycobalamin has been recently approved in the U.S. it combines with the cyanide to form cyanocobalamin, which is vitamin B12, which can be what? Hepatically or renally excreted? Renally excreted. So this is how you treat cyanide poisoning. Kind of complicated. 3 steps. It's not like carbon monoxide where you just give them oxygen. That won't work. So moving right on to digoxin. As soon as Adobe will let me move here. Yeah, digoxin. Now this one's going to have, you're going to have decreased levels of potassium in the blood, and it can cause an increase the potential for cardiotoxicity with digoxin. This is the most commonly seen in patients who are concurrently on what? Loop diuretics, thiazides. Patients on digoxin should be treated with potassium-sparing diuretics or be given potassium supplements, no doubt. But the antidote for this is antibodies, actually. Anti-dig-fab antibodies. Did you bind heparin? We all know the treatment for heparin. So if I overdose you with heparin, what are your signs going to be? You're going to be bleeding. How about thrombocytopenia? Sure, why not? What do you give to treat heparin? Protamine sulfate. Which combines ionically in a 1-to-1 ratio with heparin to form an inactivated compound, just in case you're wondering. So iron, how do I treat iron overdose? Deferoxamine. Some symptoms of iron overdose: you're going to have a bloody diarrhea. So this could kind of confuse some docs. You're going to have a acute bloody diarrhea. You're also going to have confusion, and you're also going to have metabolic acidosis from chronic iron exposure. So this one's from chronic. With chronic iron overload, hemochromatosis may develop, so too many blood transfusions, you're going to get a restrictive cardiomyopathy, you're going to get joint pain, you're going to get brittle diabetes or bronze diabetes. This is all the same thing, but you use deferoxamine to control this. So isoniazid, what do you do if you overdose on that? What do you think the treatment is? Treatment for this guy is pyridoxine. And what you would expect to see if you overdosed on isoniazid is a peripheral neuropathy. You got to put the B6. You got to put the B6 back. So you're going to see confusion. The big one's peripheral neuropathy, seizures. It's hepatotoxic, etc. So what about lead? Lead. This is the one where you got to do a couple things. You got 3 antidotes. So treatment. Number 1, you can do the EDTA challenge. Number 2, you can do penicillamine. And number 3, one we all love, dimercaprol. So symptoms, you're going to see, what type of anemia are you going to see with lead poisoning? You're going to see a microcytic anemia. So it's going to be below 80 on the hemoglobin count, right? You're also going to see purple lines on the gingiva. You're going to have a peripheral neuropathy. So maybe you look for something like wrist and foot drop, ataxia, who knows? Lead lines. Anyway, moving right on to methemoglobin. Methemoglobin, what do you give right here? Methylene blue. This one's going to be, if you overdose somebody on methemoglobin, you're going to have a confusion, cyanosis, coma, fatigue, etc. So what about the opioids? Moving on to those guys. So the treatment for opioid intoxication is naloxone. And this is going to be sedation, constipation, apnea, meiosis, except for one drug. Can anybody tell me what the one drug that will not cause meiosis is? It's meperidine. That's an opiate which causes mydriasis due to muscarinic antagonism. So, meperidine or Demerol, muscarinic antagonism, causes mydriasis, not meiosis. It's a big point there. They like to test on that. So phenobarbitals, phenobarbital and acid, what do you think? Sounds like one to me. So I'm going to go ahead and guess that. What are we going to do? We're going to give them charcoal. We're going to give them bicarb to improve the renal excretion of that. What are the symptoms going to be? Cardiac depression, hypotension, and sedation, right? All right, moving right along. Doing good. Quinidine. Quinidine, this one can lead to something called torsades de points. No bueno. On the EKG, you can't miss this guy because he just looks like this. Scribbled all over the place. Can also lead to thrombocytopenia. And tinnitus. Quinidine is not a good thing. You can also have sensionism with quinidine, where you're ringing in your ears. It's a cytochrome P450 inhibitor. It's an anti-muscarinic activity, and it can also cause drug-induced lupus. So if we overdose somebody with quinidine, what are we going to give? You're going to give IV magnesium for torsades de points. It's the only thing you can really do. And then we're on to the tricyclics. So these are all acids. What do you think we're going to do? We're going to hit them with charcoal and bicarb to do what? Improve renal excretion. And TPA, streptokinase, you only got 2 more, so hang in there. If you overdose on TPA or streptokinase, the treatment is aminocaproic acid. And what about warfarin? Warfarin toxicity, everybody loves that one. If you overdose on warfarin, you better give them FFP, fresh frozen plasma, right away, rapid, along with vitamin, which one, A, D, E, or K? That's right, K. It requires several hours, though. Several hours. So, there you go. Now, the symptoms with warfarin, remember, you can have bleeding, you can have skin necrosis, especially in patients with what? Protein C or S deficiencies. If they have a protein C deficiency and you give them warfarin, look for that skin necrosis. Don't forget that. Back to the TPA and the streptokinase. What would be the main symptom here? If you overdose somebody on TPA, what would their main symptom be? They're going to be bleeding, right? That's why we don't want you to bleed into your brain. Exactly. So that sums up pretty much everything you do if you overdose on any of these and you become toxic.